up 2, 3, 4, 5% the max, just because we have such a high volume of patients. As you know, there are about 330,000 patients in the Rhinewind program. The fact that we actually report 75,000 in the January report is a third of all Rhinewind patients are covered in the database. So there's a regression to the mean means that, we're not going to jump dramatically up. But I'm trying to figure out in my head right now, can we tell a better story of the 2, 3%? Is it by number of patients who are now virally suppressed? Is it a percentage change from where we started? I think the data looks great because it goes in the right direction. Also, it's worth noting that the national Rhinewind average is about 90.4%. Somebody will correct me on that. So any suggestion how we can tell the story differently? Rather than saying 2%, which some people are like, well, that's wonderful, but what else? How can we make it either graphically or story-wise differently? Any suggestions are welcome. At the end of the day, we as AQI can tell a story on behalf of the collaborative, to HRSA and everybody who listens, but also we want to make that tool available to you so you can tell a story to your senior leaders. Any grandiose ideas? No worries about Lily. I'm rephrasing the question. We know that the data went up from the very beginning where we started. All the indicators went up by 2 or 3% on average from the starting point. So baseline to March data. How can we tell the story of 2% differently?
Christina shared something in the chat about representing it as a number of people versus percentage, which I think would be definitely a lot more impactful.
Particularly when the N is so strong, or Michelle, when we have 75,000, maybe we can say what's the numerator denominator in the chart below, and that would say, well, now we have, we started out with 5,000 patients not virally suppressed. Now there are 3,000. I mean, that means that I'm making numbers up here, but that means that 2,000 patients are now virally suppressed. That's a number. If I go back, we know that the annual cost for somebody on HIV is about $30,000-$40,000 a year. And we can say, well, we can prevent transmission if somebody's virally suppressed. I sort of tell a story through that. We tried it before to make a business case for getting somebody virally suppressed. Well, I like the idea of that. Any other suggestions? We can plugging away, particularly we can use that because I see on those storyboards what you will have. Lily, the question is, maybe, Michelle, do you want to pull up the slide for the March data over time with the March data? So we saw an increase of data over time for the indicator of virus suppression, retention, and linkage to care. But the data are incrementally, so it changed probably from 85 to 88%. That's what I remember from the data. And then the question is if that means a 3% change. How can we tell the story differently? So 3% for some senior leaders are like, well, it's just 3%. But 3% out of 75,000 is a significant amount. I think it's slide number, if you go back in slides. One more. Yeah, that one. So virus suppression, 85 to 88%. How can we tell that increase slightly different to be more impactful?
We have a few things in the chat comments.
Is there a way to extrapolate that to show a number of reinfections? I'm trying to think out loud. We do know that, and if I get the numbers in my head right now, but if you have 100 patients with HIV who are not virally suppressed. That could be in care, out of care, don't know the HIV status. They transmit HIV to 100 people that are in this category. They will infect 2 to 3 people. So the transmission rate is then 2%, 2 to 3%. And so what we are saying is by getting virally suppressed, you're preventing those 2 to 3 HIV transmissions by 100 people. So we could make the case that I don't know what it plays out, what is 3% of 43,000 patients. So that will be the number of patients, and then calculate through how many HIV transmissions we have prevented. Michelle, we did that before, correct? For some of the end reports of our collaboratives.
Yes, we might have done that for Impact Now, I believe, or maybe cluster detection.
So maybe what we could do is maybe to bring back the calculations, see whether there's any updated literature, and then have maybe add one slide to this report for the next data cycle, and then see how many HIV transmissions we estimated to have prevented. Rebecca, do you want to go offline a little bit and then tell your point?
Well, one of the things that I feel can sometimes make viral suppression look good, but it's maybe a less impactful story is we get people that transfer into our program, so we just have more people, but they're already engaged in care. So they're transferring and they're coming in undetectable, which increases our total people that are undetectable. And then a lot of our detectable humans are still kind of just lingering because they have a lot of other, problems in their life that are not HIV and that are their focus. So it makes like a good story if you're like, well, overall, our detectability has decreased because that's great. That reduces transmission, but it makes a better story to say our viral suppression increased because these people that were detectable have now become undetectable, rather than saying what could be more true depending on the clinic, which is we just got an influx of patients from a different practice that were already undetectable, if that makes sense.
So basically, what I'm trying to operationalize what you just said, Rebecca, and one of the things could be to also this measure wouldn't be because we can do this as part of our last learning session in December kind of activity where we can figure out like how many patients were in care with your program for over a year or more, and out of those, how many became from. So you establish how many were in your program for at least 6 months, and out of those, how many became virally suppressed. So that to account for those patients who just came in the last few months. Because we assume if you are a new patient, you come in your program, you're not virally suppressed, it takes about a few weeks, a few months, 6 months, let's say, to get somebody virally suppressed. So once you establish that, you take out the variable that is somebody just coming into it. When because they put in the numbers that some calculations. So thanks for doing that.
We had one more comment in the chat from Lily with regards to challenges with their retention and care data. Lily, if you don't mind, just unmuting before we jump over to Afasana sharing how they do their Epic data. Just unmute and share what are some of the concerns you're having around your retention and care data.
Um, yeah, I think I mentioned this at one of our prior meetings. So initially, when we started out, we weren't tracking that retention in care. We were tracking gap in care. And so when we joined this collaborative, we worked with our analytics team and built out like a Tableau dashboard to track retention in care. But our viral suppression rate is in the high 90s, like 94%, and our linkage in care is well into the high 80s. But that retention in care seems to be around 69 to 73%. It kind of fluctuates every reporting period, but I'm just having a hard time believing that we are truly accurately capturing retention in care. And I don't know if it's like a data systems issue, if it's a SQL code issue, but I've been trying for months, trying to like hone things and see if like maybe we're not capturing everything. I suspect it has something to do with like fully capturing all of the viral load tests. I don't know, but seems to be like an ongoing challenge. And I think I've reached out a few times to see if there were like any sort of like resources. Um,
One thing I suggest to you, when I was in the clinic and we had several thousand patients, so it's very hard to do a chart review of 1,000 patients
mhm,
and you have to verify whether or not. I would say start with randomly picking 20 records
mhm.
where you know that met certain criteria. They had a lab drawn, they have this, they have that. And then look those 20 patients and then look whether the report that you get on the other end of it, whether those two are matching. And
Okay.
start with a very few patients. Look for very specific criteria. And then, okay, all 20, let's say you pick 10 and all 10 met that criteria. Then you look for other criteria. They are not virally suppressed. They had a viral load, but it was, certain things, and then look again in the report. And so if you do it multiple times with different criteria, then you can eyeball where that problem may or may occur.
Okay. Yeah. I did chart check like a few, not up to 20, but I haven't really seen like a trend, but I'll take that suggestion and
Yeah.
maybe do like a deeper dive.
But I would say write down on a piece of paper, like
Yeah.
which patient are you picking? There are had no viral, had a viral load twice a year, this and this
Mhm.
and that. So then that needs to be picked up in the report
Yeah.
versus randomly, because then you don't know what you're looking for. And
Mhm.
then you look, once you do that, and then you look for different criteria. And then, just do that.
And I feel like that is a perfect segue into Afasan presentation. Oh, oh no, I didn't pick your question by accident. It just happened to be perfect segue. So Afasana, I'm gonna go back ahead and share my screen. Um,
Thank you, Elena.
you're most welcome. Let me just find the screen I'm sharing. All right, Afasana, I got what you're looking at. I know we kind of adjusted a little bit formatting, but this is still your slide deck.
Yeah, that's fine. That's okay. Thank you so much, Elena. So a little brief introduction about me. I'm the programmer analyst at UCSD Wen Clinic. I am Clarity certified for both the Clarity data model and Clarity tools administration. So mainly, I use MS SQL for the data query and for all the reportings in the Wen Clinic, and I am responsible for all the data reporting at Wen Clinic. So we do, can we go to the first slide? So yeah, thank you. On a regular basis, every month, we do our CQI and our internal pop health meeting. We meet with all the members, and there we present our internal measures or metrics that we do rolling 12 months, previous 12 months. So this slide that is showing is the rolling 12 months for those patients. So this is the slide on our new patient measure that we say. And by new patient, we define it patient who had an intake in the previous 12 months. with us. So, and then we do two measure in here. One is engaged in care. That means, and these are our internal measures. Engaged in care, we do that on the new patient measure, the patient who are engaged in care. That means the definition is who had a visit with our provider within 6 months from the completed intake. And the second measure that we do is time to virally suppress, who are not suppressed at the time of intake. So we do that on an average, patients who are suppressed in the rolling 12 months. Now, how many patients are suppressed and what is the average time to be suppressed for these patients? So these are the two measures that we do on our new patient. Again, the way that we define the new patient is who had an intake with us in the previous 12 months. So any question on this slide? And then we do so many other things on this group of patients who are not yet virally suppressed. Who are these patients? They had a visit with us. Did we lose them? Or they had a visit, they're engaged but not yet suppressed, or they didn't have a visit and we never see them again. So who are these patients? So we, slice and dice the group who are not yet virally suppressed. That's how we do that. And this slide is all about that. Any question on this?
I have a question.
Mhm.
I was looking at your new number of new patients currently not virally suppressed, looking at never had completed visit after intake.
Mhm.
I guess my question is, do you guys have a rapid start protocol? How does that fit into this as far as getting them tested, medication, visit, all of that? Or maybe I'm not understanding the data that I'm looking at.
Yeah,
Apologies.
these are the patients that never had a visit. Maybe they are getting care somewhere else, not with us. But the way that we analyze the data, that we want to see that the who are not yet suppressed, are they with us? And then we need to put any or do any intervention for them? And if they don't take engaged with us, then we send those list of patients. And if they're like 12 months out of care, we said that's like a totally different scenario. But this slide is just for the two measures that we do. And then there are other reporting we do, patient are who are not in care with us or 12 months gap in care or out of care. We send that data to the San Diego counties to see if they are getting care somewhere else. Try to track where those patients are who are not engaged with us or not retained with us or who are out of care. Did I answer your question?
Was that helpful, Ziamara?
Yeah, I think so.
Okay, then anything, if no other question, then we can go to the next slide with our active patient measures. So this measure we do every month. And again, this is like 12 months. I think we got what the average date to suppression is. Yeah, we do have in the previous slide, Winnie, it is like currently we are maybe 59 days. Can you go to the previous slide, Elena? Because we have a question in the chat. Winnie asked, yeah, we have right now, currently it's 59 days on an average patient, like on an average time to get very suppressed.
I guess my question is regarding, you say new patients, but they're new patients to you, but they're not newly diagnosed.
No, no,
Okay,
we don't do
that was
testing.
my confusion then. Now I
Okay, yeah, that's why I'm saying like repeatedly, like the new patient, we define it patient who had an intake with us because we do not do testing. Yes, our
okay.
site, we do not do testing at our site. Yeah. So next slide, please, Elena. This slide shows the active patient measures. That means the patients who are had a visit with us in previous 12 months. And this is the most recent one that we have presented in this month's CQY. Excuse me. And then we can see like, and then we do retention, and this retention is based on the new measure that the CQII We got it from this training, and I have updated that our retention definition based on that. And then we have how many patients are on ART for at least 6 months, and then how many patients did the viral load testing within the reporting period and virally suppressed. So in column F and G, we have both our internal and our have definition for the viral load suppression rate, where the denominator is slightly different. And then we have some additional internal measure. We want to see how many patients did the viral load testing and on ART for at least 6 months, and of them, how many are virally suppressed. Just this is a subgroup of the of those patients that we want to see how many patients did the testing and are on ART and virally suppressed, and who are not virally suppressed. And then we do the CD4 who are less than 200, and how many of them are on medication for PCP prophylaxis. So these are the measure for our active patients. And the active patient we define who had a visit, at least one visit with us in the previous 12 months. And these are all these metrics. I use the MS SQL tool to calculate them. And then I'm going to show you in the next couple of slides that right now we don't even do that manually. So can you go to the next slide, please, Elena? Thank you. This is the control chart. It's like it's coming from the previous chart, how we are doing what is the trend line in previous 12 months for the viral load suppression rate, how we are doing here. So just to see if we are like doing something different or something drastic happen. It looks like we are right now, and this is based on our internal measure for the retention for the viral load definition, where the denominator is patients who had the viral load testing instead of the who had a visit in previous 12 months. So can you go, any question on this one? No. Okay. Can you go to the next slide? Okay. Oh, sorry. This is the retention rate. Maybe I put the wrong title on this slide. This is the retention rate trend line. As we can see, after we defined the definition, with the new definition for retention rate, we are doing much better now. Sorry, that was okay. What's going on?
I updated it for you. Can you still see my screen?
Okay, so this is just the trend line for the retention rate. So these are the measures we do on our active patient. So in previous 4 slides, that's how we are showing that we follow the trend line for the viral load for the retention rate, and then we do all those measures on our active patients. Can you go to the next slide, please? This slide, this is our internal measure where we do linkage or access to care, even though this is not, as I have already mentioned, that we do not do testing. So this is the way that we define it. It's an internal measure for one clinic. And we want to see that by saying access to care, we see patients from the time they call for the intake and what is the date or the time they get the appointment really. How much is the waiting time between the call and the appointment date for the intake? And then here we have the target here is 7 days. So a patient should get an appointment for intake within 7 days from the time they call for the appointment. And in the month of February, we have 8 days average waiting time, which is a bit high than our target. So, and then in the month of February, we have like 59 appointments made. And then we want to see how many is below or above the target line. And of the patients who had above the target line, do they have any preference that if we have that in our EHR, sometimes patients say that they have a specific date, that they need a specific provider they want to do intake. So we exclude them when we calculate the average waiting time. Excuse me.
Michelle, do you have a question? I see your hand is raised.
I do. Asana, I just wanted to ask, do you have a separate linkage visit from a provider visit?
We do have an intake visit. Yeah, these are all the intake visits. Yeah, this is
Okay,
not a
so
provider
but that
visit.
doesn't mean that they saw a provider that day.
No,
This
no,
is
no, no.
intake
The
into
next
the
slide
program.
will show. Yeah, the next
Okay.
slide will show, Michelle. Yeah, yeah, yeah. Yeah. So if we go to the next slide, this slide is showing so we do two measure for the linkage or access to care. One is to get the appointment for intake, and the second one is after the patient completed the intake, how much time the patient need get to get an appointment with the provider. So this is another measure we do, and this is the visit you are talking about, Michelle. This visit is with the provider. So here the average target waiting time is 14 days. But in the month of February, you see that we have an 90 days waiting. So after the completed intake, the patient had to wait on an average 19 days to get the appointment with the provider. Yeah, this is how we measure these two metrics for access to care in our clinic.
Thoughts, comments, or questions here? I particularly like Afasana, how your clinic is looking not just at the intake, but how long it takes from the intake for them to actually sit with a provider.
Yes.
I'm gonna let
Yeah.
you. Oh, there's there's a few things coming in the chat.
This is really way to check on patient wait time.
All right, Afasana, next slide.
Yeah, so these two are just the trend line for the waiting time for those two metrics I just showed. So over the previous 12 months, how we are doing on the waiting time. So this is just a trend line to check. And if we go to the next slide, so what I was saying that all these metrics, especially the retention and the viral load, and then we also have some internal pop health metrics that we run. Are these specific to particular physician? No, these are not specific for a particular physician. These are for the overall clinic cohort we need. Yeah. But we do have like if if some providers say for my panel who are the patient are not retained, we do that. We send them that, okay, this is your panel, and of these patients, these are the patients who are not retained in your panel. Provider specifics wants to. Yeah, like we don't do any provider specific data unless the provider asks for it. And this is the I was trying to show you this so we do have now all the metrics in our Tableau dashboard. So we don't really manually run every month all these metrics. What we do, what I did, so all these SQL code, I run them. I went to the SQL reviewer team, and they reviewed that and see how much time it takes to run it. So all these technical things after happen, we send the code to the data integrity team, UCSD, and they are the one who schedule the job to run. So right now, currently, all of my code runs first Monday every month. On a monthly basis, the first Monday of every month they run, and it gets updated in the Tableau. So maybe let me, if I can share my screen, I can show you our Tableau a little bit. Let me go to the Tableau so that you guys can see. I just want to show you how in the real um, time the the data looks. It takes a bit time to, yeah, maybe, yeah. Okay, I have it. So can I share my screen?
You should be able to go ahead.
Okay, thank you. So this is our Tableau. So everybody in our When Clinic team has access to this Tableau, and here we have all these like our active HIV patients, the retention rate, viral suppression rate, and by demographics we have that, and also the clinic's new patients and their measures. So all of these measures and active patients, the population distribution also we have it in here. So, and the appointment date, time, no-show rate, late cancellation rate, we have everything. And then we can see that it was lastly updated on March 2nd. So this is how we do that in our Tableau. And then what Winnie was saying, like if it is provider specific, the provider can go there and then see like if they click or they want to see for their patients who are not retained, they can see that, or I can send them that. And also we have our internal pop health measures in our Tableau that also gets updated. So internally, what are the we do have some STI screening. We have pneumococcal vaccine screening, hepatitis C, depression screening. So all those are also updates in Tableau, and these are also by patient demographics. We do that to see if we can figure out or nail down any subpopulation that we need to intervene. And then we also have the trend line for that also gets updated for the retention and viral suppression rate that I showed in the slide. And then we have the metrics definition in here. So if anybody wants to see what is what, they can go and check. So this is our Tableau now. And this gets updated every month. Any question? I think someone
You have
raised.
one hand raised and a few things in the chat. And that dashboard looked really good after that. Go
Yes.
ahead, Abdallah.
Hello. I had a question about how you're doing the overtime data points. Are you doing that at runtime, for example? Because I would assume each of those data points are rolling 12 months themselves. Do you store that data each month in a table, or is it at runtime, each of those data points?
Yes. No, we don't stack them. So if we have the 12 months, it's just, the next 12 months, the previous 12 months will data gets stored somewhere else. And then the new 12 months data will, update it. That's how it's not like stacking, like every month the data is stacking in the database. No, we don't do that.
Okay, so at runtime, then, for example, if you had a December report, you would have the January number. Would you run the January number in December again? Or is it because you said I guess you're saving it somewhere, and that's how you pull the January number from the January at
Yeah, like
runtime?
definitely, I can do it manually. Like if a provider asking me to report, like see how many I saw in 2025, I will run it in SQL, like from January to December 2025, how many patients, Dr. Lonergan saw. Yeah, we can do that. But in Tableau, we have always the most updated 12 months.
Okay, so for example, the January number that you're comparing in December is the January number that you ran in January.
Yes.
Okay.
Yes. So it gets updated every month. The first Monday of every month, the data gets updated. And the trend line I showed, it just get that summary, the percentage. I have another table, and that is also gets updated. And then the data pulls from there.
Oh, okay. So
They're
you do
like
have a table.
yeah. So I have a for these Tableau dashboard that I showed, I have one, two, three, five different data source. The Tableau is getting data from five different data sources and then puts together the dashboard. So the summary or the trend line that you're seeing, that every month the data runs, another data source got the summary level data and then keep it. So then it runs again. That is a stacking, yeah, the summary level data.
Gotcha, gotcha. Okay. Yeah, that answers my question. Thank you.
Sure.
Did you say that you can get patient level data on your dashboard? You
No,
talked about providers wanting.
no, if the patient provider asks, we do that. We don't have any PHI or any
Okay.
provider level data in our dashboard.
Yeah, that makes sense. I was just like, wait a minute, did I hear that correctly?
Yes.
Thank you so much, Afasana, for sharing. I know there were some questions in the chat. People were like, I need a screenshot of this dashboard or this Tableau. So we will share this recording. This call is being recorded. We will share this recording for you to go back and kind of have a view of those dashboard. And you can maybe print screen or screen shot the recording so you can keep a capture of Afasana's dashboard. Again, thank you, Afasana. I think that is well thought out of how you guys look at your data and really piece together all those subpopulations to ensure that everyone is either linked to care within the time or linked to a provider and retained in care. So thank you for sharing that. Now, I know we've had some questions with regards to some of the data challenges. Like, what are some of the challenges we're having? And I hear some of you guys kind of came off mute and asked your questions. So we're going to pivot for the last few minutes of this data affinity group and kind of share some of those challenges. And Ziamar from Metro Health was very active in learning session 3 in the chat, just sharing some of the data challenges her site has been having. So she has graciously volunteered to kind of talk through and share so that we can talk with each other about some of these challenges. So without further ado, Afasana from Metro Health, you're up.
Hi, everyone. Yeah, so yeah, I guess I'm too active in the learning sessions because I get pulled into doing these things, but
That's a great thing. We love you.
but I mean, after hearing about how other people capture data, I know we've had so much issues. Like, first I can say is that we're not even looking at data from Epic because we don't have it structured and created in a way that we can actually pull good data. We're relying on CareWare data, which isn't the best because the metrics don't quite align, like with retention. Like I'm not 100% confident that our percentages are accurate when it comes to retention. How is it being pulled to show patients are meeting that metric, that they're going to a medical appointment and having a viral load? Like we get viral load pulled into CareWare, sure, but the medical appointment piece is the part that I can't wrap my head around. And I know our funders are aware of that because they're the ones that provide us the data and they're trying to work through that. But I'd like to have, like, my dream has always been to have a dashboard, and I think you showed me something that I have not seen before that I feel like it is possible to do in Epic, because I do play around with Tableau on a regular basis, but we've never had our own dashboard, and it's something I've been asking for. So I think that's the biggest challenge, is not being able to pull the data from Epic to really show what we're doing. I started writing some barriers here because I wasn't as prepared as I'd like, because I wanted to do some slides, but I did not. But I think being able to have the Tableau data like you have really would help us identify the gaps. We don't have a really good mechanism to figure out where should we target, right? A lot of it is we're just going off of what our funders are telling us, like, hey, these are our high need populations. This is who you should focus on, because it's always either the youth or, MSM. But really, we should be looking at our patients and looking to see where the gaps are, where in the demographics. Is it our younger folks? Is it our Latino patients? Or, it's very specific to every organization. And so we don't have a good mechanism to do that. So we're really like testing things out and just seeing who really needs it, who doesn't. Looking at no shows and things like that. But again, we have data in all of these different places. Like you said, oh, it comes from 5 different sources, but it's not going into one place to really show the picture of what we're doing. We don't have a good way of sharing our story and showing people like, we know we do amazing work. We know that because we hear it from our patients and, our viral suppression, I know is well over 80%, but there's always room for improvement and we just don't have a good way of doing that. So that's my biggest frustration is not having a really good way of looking at it from not just from like a Tableau perspective where you're looking at it from a high level, but also patient level data so that because my other dream is to have a dashboard in Epic, which has been started, but it's not quite what I envision is every provider should be able to pull down and drill down which patients are not virally suppressed that are their patients who have missed an appointment and all of that, but not just physicians. I want it to be from a medical case manager perspective, like their caseload. Who are the people who are not virally suppressed? Who should they be following up with? Who missed their appointment? Who hasn't been in 6 months or hasn't gotten a lab work? Because patients are just falling through the cracks. We have community health workers working with patients who have their own populations. And so my dream is to have everyone be able to like add someone into their caseload and be able to follow that patient through so that they don't fall through the cracks instead of doing it manually. Like we use spreadsheets, we use patient lists in Epic. So that's again my frustration is the data's there. It's just not quite organized in a way that we can visualize it the way you just demonstrated today. That looked amazing. And so it just was a light bulb for me. And that's why I speak up because I get so like, wait, what? Who's doing this? What? Like, and my suggestion for the Care Collaborative is if it would be nice to have a session where people shared how they collect their data, how they look at their data. Are they using Tableau? Are they using Epic? And kind of sharing it just how Afsana had shared during the learning session 3, which gave me a light bulb, and just because again, we can't translate everything from institution to institution, but like we can get some snippets and some nuggets there where we're like, oh, I can try this, or I know what the verbiage or what it should look like. Because I think my biggest challenge too is that I'm not a data person. So I'm relying on like my informatics team to tell me how things should be built, and I don't know how to ask them how things should be built and what's the capabilities that Epic has and Tableau has. So that's my struggle too, is not knowing what the right terminology or how it should look like because I'm just guessing. But when I see examples, I can easily pull from that and say, this is what I need based on how it should be for us versus how it is for others. So I don't know if anyone else wants to share. I mean, that's really all I have is the frustration of not having clear, clean data to rely on to really push things through, to really show that we're making an impact when we decide we want to try an intervention and we want to test things out. Like it's just more on an individual basis when we see there's some good things happening, but overall we want to see how we're making an impact.
ZMR, I think that was a lot for just one challenge overall. So don't feel like you needed to add anything else because I think the frustration is shared among your peers. We have the data, but we don't know what to ask when it comes to our EMRs, or we need them to filter and pull from us. And I think Afasana's metrics were very helpful. And this, for the point of having this space, is for us to, as a collaborative, kind of see what's helpful for you all as you look at your data. But I'll leave space. I know when you shared something and Lily shared the similar frustration as you. So Winnie, if you want to unmute and share a little bit, and if anyone has any solutions or anything they want to talk to or have similar frustrations as EMR, feel free to unmute. We have about a few minutes left to talk through this. Winnie, you want to share what specific logistic questions you're
Yeah,
on?
so we also kind of use Tableau. We don't have dashboards that automatically go in there, but we also have similar dashboards in Tableau that we kind of take a look at to get like a bird's eye view of where things are. But I think recently what we have been doing is using this statistical software called R to do regression models, and then you can statistically prove that, okay, this particular age group or this particular ethnicity has a higher disparity. Like, for example, when we looked at suppression rates, we kind of had an idea that, okay, maybe the younger age groups are not being suppressed as much as the older population, right? So, but when we look at just the percentage wise, it was like 87% versus it was like 96%. So when we put in the dashboard, but when we took that data, the raw data, and put it into the R software and did the regression analysis model, we found that people that are 25 to 44 years of age have 3.5 times chance of being virally not suppressed compared to people that are above 65. So that, when you just look at the percentage points, it was like, less than 10 percentage. But when we run the model in R, we found like with these, people that are between 25 to 45 years of age have almost 3.5 times probability of not being widely suppressed compared to those that are above 65. Then it was like, oh, okay, that kind of helped, uh, clarify the point and underline the importance of focusing in on that particular group. So if and I do have some background in using R and stuff like that. So we kind of use that in addition to uh, like dashboards to really like statistically prove and it underlines that message even more, I feel like. So I just want to put that in there.
Thank you, Winnie. And Lily would love to see what that the graphics look like for that R software. And if you can, maybe share that specific software and where your peers can maybe find it or look at it or play around a little bit to see if it's something that they can utilize in their agency. And then Afasana wants to know if there any control variables are you using in the regression?
Yeah, so the control variables, you kind of have to, there's a lot of data that goes into the raw data itself, right? There's age, there's ethnicity, there's, oh, hundreds ways to slice and dice the data, right? So you kind of have to have like a general overview, I would say. So that's where the dashboard helps. So if we can control so we can see that there's a big disparity when we're looking at the age dashboard, then we can keep most of the other race and ethnicity control for those, and then focusing on the age group and look at the age specifically, if that made sense. But I think using the dashboard and a little bit more and leverage that with the software, uh, the statistical software, I think kind of helped us and helped me in, pushing that point forward to the hires above.
When you can do a proportional chi-square test, like the simple test you can do in Excel. To see if there is a significant difference.
Yeah, but I think when I was presenting the data, I think the chance, 3 times chance, 4 times chance, that kind of helps deliver the point more, I felt like, rather than just saying, oh yeah, there's just a difference, but how much difference, right? So
Yes,
if we can put like in the terms of odds, especially since everybody's into betting and so on and so forth. So using it in the terms of probability, that I thought like helped with the point that I was making. So yeah, but it is a lot of you kind of have to clean up the data first so that R understands it. And R is, I think it's freely available software too, and there are a lot of good online resources, like even if you go into YouTube, they take you to, and I learned most of the stuff through YouTube. So.
Awesome. Thank you, Afasana. Your expertise has been requested for a training, just as an FYI. But we have 2 more minutes left. I just wanted to just share some things with you all just before we close out today. This was helpful as we think through how we can continue to support the sites participating in this collaborative, particularly around your data. And as I mentioned earlier, we will be focusing a little bit about the data and learning session 4. So we wanted to hear what are some of the challenges you're having and seeing some of the metrics your peers are utilizing for this collaborative. Just to think about, we have our TA webinar coming up next month, which will focus on your data drill downs. And as we all know, data drill downs go beyond the what. So It looks the report to allow the specific data summaries on those granular details, those subpopulations that are just falling through the cracks. So we're excited to see what you all pull from that. I'm not sharing screen because why not? Forgot I'm just talking through and not saying anything to you all. Just a brief reminder. And then of course it swapped how I wanted it to swap. So reminder, your data submission number 5 was due on March 20th. Be sure to upload that to the collaborative database if you have not. If you are a representative of your team and they're not here and the data person needs to be pinged, just ping them and let them know that submission was due. And again, we have the data drill down webinars that are on the 14th and the 22nd. If time allows, we highly recommend you coming to the first session, just because when it comes to getting prepared for your storyboard for learning session 4, we want to make sure that you all have at least watched this data drill down presentation and have had the time to meet with your coach and start doing your own specific data drill down. So please, 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 please remind your teams to attend the TA webinar, the 14th and the 22nd. The first session is at 2 p.m. and the second one is at 3 p.m. And again, this session would assist you in your data drill down as a leading to learning session 4. Any questions or comments or thoughts before I close out? Oh, thank you, Winnie. And Winnie did share that specific R software that his agency utilizes. And on that note, it is 3 o'clock. I thank you all for the amazing work that you're putting forth, the time you're taking to sit with us, and those improvements you're looking to ensure that your patients get access and equitable care. So I thank you. I wish you all an amazing rest of your week, and I'll see you in future meetings.
Thank you.
Thank you all.
Thank you.
Bye, everyone. Thank you.
No, Michelle, I swore I was recording, but now I'm looking and it says like it's not, was this not recording this whole time?
No, it is recording. I
Okay.
see it in the corner. Yeah.
Oh, okay. For whatever reason, oh, there